Hi, welcome to the Injury and Violence Prevention video lecture series. Today's topic is health behavior and health education examples from injury prevention. This is part of a series that was developed through a collaboration between SAVIR and Safe States. It's part of a larger CDC funded initiative where we've invited people to provide information and examples that can be used in a variety of educational settings. The aims of this series are to raise awareness about the field of injury and violence prevention among students, professors, and practice professionals, and to familiarize all public health students with a basic understanding of injury and violence prevention. My name's Andrea Gielen. I'm a professor emerita at the Johns Hopkins Bloomberg School of Public Health, where I had the pleasure and privilege of directing the Johns Hopkins Center for Injury Research and Policy for a number of years. So I'm delighted to be here with you now and to go over a PRECEDE PROCEED planning framework. And I hope through our time together, you'll be able to identify at least three examples of behaviors that reduce the risk of childhood injury, become skilled in building effective behavior change programs using the PRECEDE PROCEED planning framework, and to give examples of three types of intervention strategies that are effective for addressing predisposing, reinforcing, and enabling factors. And for those of you who may be familiar with the PRECEDE PROCEED planning framework, I should say that I'm presenting the updated model. So for you all, it may be a refresher plus an update because a new model came out just a couple years ago. And that's the one I'll be using. And through our time together, I'll be addressing some of the Council on Education for Public Health criteria that you see listed here, which includes assessing population's needs, assets, and capacities to apply awareness of cultural values and practices to the programs and policies we design, and to design a population-based policy or program or project or intervention, and to also be able to select specific communication strategies for different purposes. So let's get started. I have the content divided into three sections. First, an introduction to the model. A second, applications of the model in a real world setting, and wrapping up with some summary. So imagine that you have just been hired in your local health department. Your first assignment is to reduce the county's rate of childhood injury. So you've been given a health problem and you're expected to solve it. So you may feel like you're lost in a maze of options. Well, PRECEDE PROCEED is your roadmap to success. It's a planning model that was first created in the late 1970s. It's been widely used nationally and internationally to address numerous health issues, and it's now in its fifth edition, which is the one I'll be referring to. So here is the whole model and in all its splendor. And let's start looking at it from left to right. We're over here in the left where we have intervention strategies, implementation strategies, evaluation strategies, and we implement and evaluate our policy and programs. So that's the what we're going to do. And the reason we're going to do it, if you haven't really articulated it, it's in your head, I'm sure, is you expect a chain of events to happen to solve a problem. And here we see that chain of events is divided into predisposing, reinforcing, and enabling factors, which will become clear as we go along. Don't let the jargon throw you. And those things that are affected will then change a behavior and an environment and lead to a health outcome, which will lead to improved quality of life for the people that you're trying to serve. Now, how we get to that program on the left-hand side is through a series of phases, planning phases that you see listed here. From now, we read from right to left, where we have the social assessment, the epidemiological assessment, educational and ecological assessment, and then we develop our health program and policies. We then are ready to go around the bend to our final phases where we implement and evaluate a process evaluation, short-term and intermediate evaluation, and long-term outcomes on health and quality of life. So let's dig into it by looking at the example of childhood injury. Oops, I have to go back. So, why childhood injuries? Well, if you didn't already know it, I'm here to tell you that injury is the leading cause of death for children in the United States. Sadly, it's been the leading cause of death for many years since I started in the field. And here we can see how it affects the youngest of our kids. So this is death rates for children ages 1 to 14 by cause of death and age group in 2021, which were the latest year that was available when I made this recently. And the first bars are the ages 1 to 4, and the second bars are the ages 5 to 14. And you can see, reading from left to right, unintentional injuries are the leading cause for both age groups, although the 1 to 4-year-old rate is much higher. These are death rates per 100,000 children. Um, and then you can see birth defects comes in second, followed by homicide, cancer, and suicide, heart disease, COVID, and influenza and pneumonia. Now, if we add homicide and suicide, which are considered intentional injuries, you can see that intentional injury and violence affect way more children than any of the other diseases. Today, we're going to focus on unintentional injuries in our examples, but let's look more broadly for just another minute because I want to give you a sense of what the causes of death and and non-fatal injuries are, because they tell an interesting story. So first of all, this is the tip of the iceberg is the deaths at 3,487 compared to 1.7 million non-fatal injuries. Now, non-fatal injuries are those things that you get treated in the emergency department or as an inpatient in a hospital. And if any of you have experienced either of those things, you know how devastating and life-altering non-fatal events can actually be in terms of your quality of life and your health outcomes. So that is a big number and a big difference between the number of deaths and the number of non-fatal injuries. And similarly, the causes of the deaths and the non-fatal injuries differ. And you can see the top 5 listed here for deaths, which run from suffocation, drowning, poisoning, burns, and falls are the leading causes of death. And the leading causes of non-fatal injuries are falls, being struck by or against an object, being cut, being burned, which includes scald burns and fire burns, and poisoning of all sorts. One of the sad realities of that state of affairs is that there are many evidence-based safety practices and products available, in particular for preventing children's home injuries. And when you're thinking about the youngest children, the 0 to 4-year-olds, which is what we're going to focus on for the rest of the talk, where do those children spend most of their time? Where are their exposures to hazards? Mostly in the home and in daycare or home or with relatives in homes. And you can see here a number of the well-established safety products and practices, from stair gates to water temperature measurements to smoke alarms to cabinet locks and latches, and to outlawing these kind of walkers that had no wheels and that had wheels but no brakes. So they are no longer available. So let's talk about one example that used precede proceed. This is the Safe Home Project. And let me give you a little bit of background, the context and the formative research that we did. We were working in East Baltimore, where the children there on medical assistance have twice the national rate of injuries. In particular, we were working in the Harriet Lane Clinic at Johns Hopkins. working with pediatricians who were providing care to children from 0 to 2 years old. And there were concerns about fires, burns, falls, and poisonings because they were an important cause of injuries, and there was a need to develop innovative programs for it. So, also, they were of interest because, as I said, there are evidence based safety behaviors available, including the ones we saw on the previous slide. But what was missing was no systematic pediatric counseling or training to help pediatricians promote these safety behaviors. So, what did we build? Well, here you see our SAFE program components. We built a program that included pediatric counseling, a children's safety resource center, a community health worker home visiting program in our effort to improve child injury outcomes among the 0 to 2 year old population. Now, what did we think was going to happen with those programs? We thought this sequence of events was going to unfold to improve the safety behaviors and the injury profile for our children. But what did they involve? Let me tell you a little bit about each of those program components, and then we'll think about what that causal chain might be. So the pediatric enhanced anticipatory guidance was a 5-hour faculty-led hands-on training program with role playing and homework where we taught a specific counseling framework that has been tied to effective behavior change counseling, where a pediatrician or a counselor would first solicit what the parent already knows and does, then provide tailored advice in that context, focusing on risks, benefits, and barriers of the behaviors that were being recommended, and then encourage parents to comply with that advice. And then the Children's Safety Resource Center was a small space that was outfitted like a home environment where we provided free personalized education about using safety products that could be demonstrated right there and could be sold to the parents or given, but at low cost, low or no cost if the family couldn't afford to pay anything. And this was set up adjacent to the clinic. And then the third component was to have a community health worker visit the client's home, personalize the education to their environment, and coach the parent on the safety product installation and tell them they could get safety products at the Children's Safety Center. Now, so what was the causal chain that we were expecting to trigger with that a set of interventions? Well, here we see the full model. The predisposing factors are the knowledge and attitudes we wanted to change were parents' perceived risks and this perceived seriousness of child home injuries to their little ones, and how they could overcome the barriers that they believed existed to doing that. The enhanced anticipatory guidance was meant to reinforce that information and provide that information in meaningful, effective ways. And also the safety products and the education that was provided in the Children's Safety Center and through the community health worker intervention was designed to address the enabling factors of cost and skills. And in turn, all three of those working together collectively should improve parent safety behaviors with regard to smoke alarms, hot water temperatures, um, stair gates, and poison storage, and eliminating baby walkers. Um, and the environmental factor, which was the access to affordable safety products, was addressed by the Safety Center. And in turn, those should reduce injury risk for fires, burns, falls, and poisonings, which was our initial charge, and thereby improve families' quality of life so they didn't have to suffer a preventable childhood injury. So, how did we evaluate these interventions? Well, I don't have time to go into the details of all the evaluation machinations that we went through. I'll just tell you we had two different cohorts of randomized trials. And the first cohort was parents who were seen by physicians who had been trained to deliver the enhanced anticipatory guidance were compared to parents who were received care from pediatricians who had not been part of that training. And what we found was that parents seen by the physicians who received the training were significantly more likely to have received counseling on 5 of the 6 safety behaviors, which we documented through audio recordings of the visits. They were also significantly more satisfied with the help their physicians provided on safety and no less satisfied with the counseling that they got on other anticipatory guidance topics. And this was important because we didn't want to be in a situation where the trained pediatricians spent all their time talking about injuries to neglect other important topics. And so we were very pleased with that. There were no differences in their safety knowledge, beliefs, and behaviors, which should not surprise people and did. The lack of behavior change did not surprise us because we have known for many, many other experiences that just providing counseling is rarely sufficient to sustain behavior change, and you need these other interventions. Which is why in cohort 2, we provided anticipatory guidance to all the patients, all the physicians had been trained by that point. And then we compared parents who visited the safety center with those who didn't, and those who got home visitors and those who didn't. And what we found was that parents who also visited the safety center had significantly more home safety behaviors in their home than parents who did not visit the safety center. We did home visits to conduct observations. And then we found that those who had gotten a home visit had no additional impacts on their safety behaviors, which we attribute could be attributed to any number of things, but which we attributed to sort of the weakness of our home visit intervention because it was a one-time visit. And for liability reasons, we were not able to actually make home modifications. So today there are many stronger home visit interventions. So this one was not as effective as some of the more intensive ones where actual changes are made in the home and there's more than one visit. But that said, the fact that the counseling and the visit to the safety center made a significant difference was helpful, was very positive and hopeful. So now let's try applying the model in another type of similar real world setting on a different topic. And we'll go through the assessment phases. We're going to use PRECEDE PROCEED to plan an infant safe sleep program. And so here we have our friend, the model, and we are going to do phase 1, the social assessment, and phase 2, the epidemiological assessment. And this is the Safe Start project, which was funded by a grant from NIH. It was a collaboration between our injury center and the Johns Hopkins Department of Pediatrics. And you can see here a picture of the Harriet Lane Clinic and the building that houses it, which is the same place we did the earlier program that we just talked about. Whoops. Okay, the first thing to do in your epidemiological assessment is to understand the health problem. You may have heard the term SUIDs, sudden unexpected infant deaths. And in 2022, there were 3,700 SUIDs in the US for 100 per 100,000 live births. It's a significant problem for infants from 0 to 1 with a highest risk of 0 to 6 months of age. And it includes 3 types of deaths. The first one is accidental suffocation and strangulation in bed, which happens when the bedding is too soft, when the baby is someone overlays on the baby if they're co-sleeping, or if the baby is on a soft surface or up against soft crib bumpers and gets wedged in there and can't breathe. The one you've probably heard more about is SIDS, which is sudden infant death syndrome, which remains unexplained after a thorough investigation. And for a long time, accidental suffocation and strangulation in bed really was not its own diagnostic category or well understood, well known. And so there were many unexplained SIDS deaths that now can be attributed to things that we know about safe sleep environments. And then the third category is the investigation was not completed or was unable to be completed. And so the breakdown across these three types of SUIDs is 41% in the 3,700 deaths I mentioned before were SIDS deaths. 28% were accidental suffocation and strangulation in bed, and 31% remained unknown. At the time of our study in Baltimore City, infant mortality rates had hit an all-time high, and that included those that were due to unsafe sleep practices. And the Baltimore City Health Department initiated the Be More for Healthy Babies initiative, which included the components you see here that were broad-reaching community outreach, free pack and plays, mass media, education for providers and patients, and for participating hospitals. All mothers at delivery were shown a video, which was a story of three Baltimore families who lost an infant due to unsafe sleep practices. So we knew that that was going on in the background, and we also looked at the ratio of racial categories who had the highest risk, and we found that 90% of the infants who died from sleep-related death between 2009 and 2015 were African Americans, while African Americans made up only 63% of the births in the city, so showing their disproportionate impact of this on that population. So, in terms of the social assessment, we want to understand our community's ultimate values, make explicit the rationale for the health problem that we're going to address, and engage the community as active partners, because we know that's a hallmark of good programs. Are programs that engage the audience as early and often as possible. So when I use the word community in this example, I'm talking about the clinic parents who we're building a program for. And you can do that assessment through surveys and interviews, or asset mapping, where you identify resources in your community, and the tried and true focus groups as another method. Now, in terms of an epidemiological assessment, you want to determine which health problems pose the greatest threat to health and quality of life and intervene on those that are most important and most changeable, and both the behavioral and the environmental risk factors for the chosen health problem. So you need to define who has the problem, which I showed you in the previous chart in terms of the community that charts and information that I showed you about SUIDs in our particular community of the clinic population. And you can do that by identifying morbidity, mortality, years of potential life lost. For other problems, you look to data from a variety of sources, from your state health department, your surveys, your literature, and you want to examine various types of risk factors. And those risk factors to consider are genetic or biologic, behavioral and lifestyle factors, and environmental factors. And when we talk about the environment, we're talking about things that can be social environment, physical environment, or the healthcare environment. So things that are external to the individual and things that the individuals at risk don't have personal control over. And typically you address environmental factors not through um, client education, for example, but through other strategies that we'll see in a minute. So I'd like you to think about where and how you could get data on the values, needs, and risk factors related to SUIDs among our Harriet Lane parents. And where could you get information on how to define the behavioral outcomes that we're seeking? And then what kinds of environmental factors might be relevant to the behavioral outcome that you're seeking? And given the context for your program, which factors are you more interested in terms of the environment? Social, physical, healthcare related, all of the above? So I encourage you to push pause, try to answer for yourself some of these questions. And when we come back, we'll look at what our team did. So please press pause, give it some thought, and I'll be back with you. So now let's look at what our team came up with. So the data sources we used were the Centers for Disease Control and Prevention, the American Academy of Pediatrics, and the research literature. And I hope one or two of these made it onto your list. We did formative research with in-depth interviews with 20 parents about their practices, their knowledge, their beliefs and barriers, what would facilitate them, doing safe sleep practices, and who could influence them. Um, and if you're interested, elicitation interviews follow a specific kind of structure in terms of asking very open ended questions to elicit unprompted uh, responses about the topic that you're interested in. Um, and then community engagement. Again, our community was the Harriet Lane clinicians and parents, and they have an advisory committee. So we tapped into those resources to get information about what was currently happening and what the resources might be for intervention and evaluation. So, what did we uncover? Well, we found that there were very specific recommendations for safe sleep from the American Academy of Pediatrics. Sleeping on the back for every sleep using a firm surface, room sharing if you wanted to instead of bed sharing, and no soft objects or loose bedding, and no smoking. So there was a study that was recent at the time that surveyed 1,000 new mothers and to ask about where they got that, if they got that kind of information from their pediatricians. And more than 50% reported that they had no advice from their pediatrician about where the baby should sleep. And 20% said they had gotten no advice about what position the baby should sleep in. And then when the authors looked at the advice parents reported having received, 25% of it was inconsistent with the current recommendations. So, in our previous research, we had found that the cost of cribs or pack and plays could be a barrier to our parents if none were available from the Be More campaign. And also, having done a number of home visits, we knew that crowded living conditions could be a problem for having safe sleep places in multiple locations in the home, because many of our families live in small high rise, well, not high rise, I mean multi-level row houses with steep stairs up to the bedroom area. And then on the main level, having living, dining, kitchen spaces together. So, how does that look in a precede proceed analysis of these two phases of our assessment? Well, you can see here that that our quality of life objective remained helping families have children who could live life to their full potential and avoid pain and suffering. And what contributed to that for in a disproportionate way to the families we were serving when they had newborns was SUID, SIDS, and the ASSB. And we knew that there were evidence-based recommendations for safety behaviors, the ABCs of safe sleep, alone, back, crib, and stopping smoking. And then in terms of environmental factors, we knew the expense of cribs was an issue. And the healthcare system inconsistencies was suggested by the research that we found and by the clinic's current practices around training. This was a residency clinic, so training their residents to provide this kind of information was not consistent, and then crowded living conditions. So that's where we landed in terms of the behavior change and the environmental changes that we wanted to see made to address this problem. So now we were ready to do the educational, ecological, and health program and policy development, which is where everybody wants to get to and wants to start at the program and policy development. But let's take a look at educational and ecological assessment and see if that helps us with building those strategies. So first, the educational and ecological assessment is to identify those predisposing, reinforcing, and enabling factors that must be changed. And if you think about all the things that can influence behavior, either in this context or in another context, if you've ever tried to change one of your own behaviors, you think you can imagine there are many, many things that influence whether you're going to do that behavior change or not. So, how do you choose? You don't just throw a lot of spaghetti at the wall and pick the ones that stick. This model will help encourage you to choose the most important and the most changeable predisposing, reinforcing, and enabling factors. Now, how do you identify that larger list? Well, again, look at the research literature, and I encourage people to look at all kinds of studies and do your own original data collection with your intended audience, and look at the experts. What do they have to say? What is their review, and what is their input? So, what are these things we call PRE? Well, the predisposing ones we've touched on a little bit. They're antecedents that provide the rationale or motivation for a behavior, the knowledge, attitudes, beliefs, preferences, existing skills, self efficacy beliefs, the things that get us in a mindset to be ready to think about changing. Now, I don't expect you to be able to read all the details on this. This is a table from the book. But the point of it is that once you identify those factors, you have help in your toolkit. There are relevant behavior change theories that you can draw on. And for predisposing factors, some of the ones listed here will be familiar to you, I'm sure. Social cognitive theory, Bandura's social cognitive theory, the stages of change, or Prochaska's behavior change. But there are a host of them to help you. And once you've identified those factors and the relevant theories, you have another toolkit full of intervention strategies. They're listed here to include things like one on one education, motivational interviewing, tailored counseling, all of these kinds of group and individual education sessions that you can hold. So it's a good set to draw from. And then reinforcing are those things that happen after a behavior that provide continuing reward or incentive for the behavior to become persistent, like social support, the influence of significant others, role modeling. These are all things that you can activate through your program to reinforce things. And you saw in the first example, and you'll see in this example, pediatricians are an important source for reinforcing factors because pediatricians are so important to new parents in particular. And think about the mom who had gotten the safe counseling in the earlier example, where the pediatrician had encouraged her to check her smoke alarms at home. And she checks them, she comes back, she tells the pediatrician, "Thank you, I checked them, they needed new batteries." And the pediatrician provides reinforcement. So glad that you were able to do that. And that will help get the parent ready to try another safer behavior. And again, here's the chart that ties the important reinforcing factors, social norms, social support, social networks, to the relevant behavior change theories. that you can then draw on. And the intervention strategies of how do you provide social support? How do you create and mobilize social networks, things that you want to remember to build into your program? And finally, enabling factors. Those things, now you've got the person, they're ready. They know they're going to get a positive reinforcement from either maybe the baby's father, the baby's grandmother, the pediatrician. They're ready to go, but they can't afford a crib. They can't afford a pack and play. So they will not be enabled to carry out the behavior that they want to carry out. So, again, something that you have to build into your program when you plan it, programs, services, and resources that allow for people to take action on the behaviors that they want to undertake. And then the last set of tools that you have here are the kinds of theories that work at organizational and community levels. So you have community-based participatory models, you have organizational change models, many to choose from. And then the kinds of intervention strategies, building community coalitions, policy advocacy. And we certainly had to do organizational development, organizational change in our intervention to build the Children's Safety Center, to get space from the hospital to build the center in, to change some of the practices of the pediatricians to help them remember to refer their parents to the safety center. So again, it's not something that you typically think about when you think about, oh, I'm going to do a health education program. I'm going to teach my patients how to do X, Y, or Z. So this model helps you see that it's that you need to have more complex thinking about how to make an effective program. Now, here's the good part. um, this is the part everybody wants to hear. The decision to place a predisposing reinforcing factor in one category or another is less important than ranking it as something that is a determinant of behavior that is worthy of your attention and finding a way to address it in the program. So, this is one of the things that the creators of the original model, Larry Green and Marshall Kruder, adhere to. So don't get your planning team all up in arms about whether something is a predisposing, reinforcing, or enabling factor. If it's important and it's changeable, you want to include it. There's this idea of collective causation where these factors interact with one another. And so as long as you are focused on the important and changeable things in building your program, you'll be in good shape. So let's take a minute and look at that. Um, Here are some of the factors, predisposing, reinforcing, and enabling type factors that could influence infant safe sleep. Parents' knowledge of child anatomy, is that important and changeable? Baby's temperament, access to affordable cribs, and your housing conditions. So take a minute, put it on pause, and think about where you would put those four factors. And then come back and we'll look at where we put them. You ready? Okay. So, parents' knowledge of child anatomy. That's definitely changeable. You can teach someone anatomy, but how important is it? In the generic sense, learning about your child's anatomy is not going to be that important for safe sleep. How about baby's temperament? If any of you have had a baby, taken care of a baby, been a baby, you probably know that your temperament, the baby's temperament, is less changeable. And it may be less important because all babies have the recommendation for safe sleep. How about access to affordable cribs? Very important, very changeable. And housing conditions, probably important as the example of having to have a pack and play. You don't want to carry it up and down stairs. Um, in crowded homes with very steep stairs, less changeable, maybe important. So you're going to have to somehow deal with it if you can. And in all of our home visits, we've encountered uh, many different kinds of housing conditions that are in need of attention. So one of the things that you can do is have resources lined up for other housing condition changes that are needed, like getting information to a landlord about compliance with certain things that may be unsafe or unhealthy in a home, or giving parents a resource sheet about who they can call for different services to come into the home that services that they might need. So to the extent that that kind of support is available, you can build that in. So even though it's maybe less changeable, if it's important, you want to think about that. So we've talked about the access to affordable cribs is very important, and we would want to build that in. Okay, so now we're ready to everybody's other favorite thing, which is to actually build the program. This is when you identify the policies, resources, and circumstances in your situation that could facilitate or hinder program implementation. And you do that by creating program objectives, timelines, um, become familiar with the organizational rules and regulations that might affect your ability to do your program, and then obviously coordinate the resources that you need. So for the Safe Start assessment for phases 3 and 4, what data sources could we use? Well, we used the research literature, we did our interviews with parents, pilot testing the intervention materials with parents. Always important to pilot test, no matter how informal or quick it has to be. You've got to have at least some input on your materials to avoid running the risk of completely missing the mark or being very inappropriate. Not that you would do that on purpose, just that's why it's important to have your audience engaged early on and often in building a program. Expert review is always great. Um, and, you'd be surprised. People who have published papers who you don't know, if you like their work, they're probably will be very happy to talk to you if you have questions and want their input. So, what did we discover in our phases 3 and 4? We discovered that most parents had heard of the ABCs, but they really didn't understand the rationale for the recommendations, and they had misconceptions. They were unaware of high risk groups, so they had knowledge gaps. Most of them felt they were the ones who decided how and where to put the infants to sleep, and they didn't feel they were much influenced by other people. So they had self efficacy for at least making the decision about how to do it. The barriers to safe sleep practices included beliefs about their experience with prior children. So they had a little bit of low perceived risk. And in terms of what we called response efficacy, because of those previous experiences, they weren't really convinced that doing the ABCs was going to make all that much difference. Um, not having resources and space for cribs. And many mothers felt that doctors didn't really know why SIDS happens, and they keep changing their minds about what we should do to prevent it. That's sometimes a common response across a number of recommendations for healthful behaviors and lifestyles that we hear. And that's something that you really do need to contend with. And especially in a case like this, where they have had other children and many times, or they do have information from others in their families who have not practiced the ABCs. In terms of what we learned from the clinic leadership, um, the residency training program had some unique opportunities because all of the pediatric residents had to complete online learning modules, and they didn't have a module on safe sleep. The preceptors for these residents were strong supporters of patient provider communication and patient education. And they had a history of working with us on the Children's Safety Center. And so the idea of resident training and patient education was something that they were very familiar with. Okay, time to pause again and have you spend a few minutes thinking through what, now that you have this assessment for phases 3 and 4, and you know something about what's going on in the clinic and the needs there and the PRE factors, take a minute, think about what your ideas are for interventions to implement and the most important changeable and factors. Okay, now that you're back, let's look at what our team came up with. Okay, here's what we prioritized in terms of our predisposing, reinforcing, and enabling factors. The knowledge gaps needed to be addressed. Response efficacy and risk perceptions needed to be addressed. We needed people to understand that their baby was at risk and that these recommendations were going to be effective, and then help them overcome their beliefs and the reality of the barriers that they faced. And so that was done through the pediatrician's anticipatory guidance, and through the distribution of free safety products that we would help teach the skills to enhance their self efficacy in using the pack and plays. And that's, you can see that in the PREs linked to the changing of the safety behaviors of alone back crib, no smoking, and addressing the expense of the cribs and the healthcare system inconsistencies and the crowded living conditions. Those were all things that we prioritized to address through changing those predisposing, reinforcing, and enabling factors. So, how to do that? To address predisposing factors generally, and in our case, specifically, you use direct communication to address predisposing factors. You use indirect communication to address reinforcing factors, which means someone other than you are communicating with your intended audience. In our case, it was the pediatricians. And then the enabling factors through community intervention. In our case, that would be with the Be More for Healthy Babies campaign and through the social workers in the clinic. So, to address the predisposing factors, we had one on one, patient centered, and interactive education on safe sleep that was provided by the health educator. And you can see here she's using a flip chart with information and pictures for the parent. So, to explain the rationale for the recommendation and explore the barriers to following them was what we wanted to do with the flip chart and the counseling. And here we show the baby's anatomy, specifically tied to safe sleep, not general. Here's baby's anatomy, because you may be confused from the prior slide, but it actually tries to provide a rationale for the ABCs, which again should address helping parents feel that it's going to be more legitimate recommendations that will have an impact and reduce risk. So that's an example from the flip chart, but here's an example which you don't need to read, which is from the curriculum, the health educator curriculum. So they have the detailed information that they then communicate in, in conversational ways with the parent while going through the flip chart. And then we had literacy friendly take home print materials that supplemented the health educator messages that we created ourselves and pilot tested and kept at a 6th grade reading level. And you can see we wrote our own, except for we found something from the Consumer Product Safety Commission that was appropriate and well done for our clients. And then the tobacco quit line, we took the information from the national or the state, I'm sorry, the state lines and just put it in format that matched our products. Addressing the reinforcing factors, we met with the Harriet Lane staff to orient them to the program and distributed program description. We worked with the social work staff to coordinate the distribution and education about pack and plays, letting them know how the health educator would be involved and what they communicated. And then I mentioned the online module we created for the pediatric residents to give them information about providing anticipatory guidance on safe sleep. And the preceptors reinforce the importance and requirement that they that they complete that module. And then enabling factors. Here we have an example of the health educator providing the pack and play and demonstrating how to use the pack and play. And these were available in the clinic if we couldn't get them from the Be More for Healthy campaign people. And one thing to point out here is just this teach back method. So the health educator instructed the parent on how the safe sleep process, putting the baby to bed and so forth, and the things to not have in the crib and so forth, and then had the parent demonstrate their understanding of it. So, how do we evaluate this now? We've turned the corner on the model and we are starting to do the evaluation. We did a randomized control trial of the standard of care versus the pediatric guidance only. The intervention visit took place at 2 weeks of age, and there were two home visit follow ups to measure the observed and self reported outcomes at 1 and 2 months of age, and a sample of 106 new moms who were an average age of 25, 43% first time moms, 93% African American, 86% on medical assistance, and 61% with a high school education or more. And so, as I said, we've turned the corner, but now you can see the entire model fleshed out with the intervention components tied to their various chain of chain of change, the causal chain we think should happen to improve the outcomes, and then how we monitored and tracked the information on implementation and the rest of the evaluation. I'll show you a snippet of that in the next slides. So at the 1 month follow-up, we looked at any clutter in the sleep product, in any sleep product that the mom showed us where the baby slept. And we saw there was the intervention group reported less likely to report having any, not report, excuse me. We were less likely to observe any clutter in the sleep spaces of the intervention group, where we observed it for 31% of the families, whereas in the standard care group, we observed clutter in 63% of the families. And that was statistically significant. That was a good finding, but still work to do to get rid of all of those sleep clutter, which included blankets, toys, pillows, the usual thing. Two homes, and I'm not sure which group, had crib bumpers in one of their sleep products, although those have been banned for sale in Maryland for a number of years, which I didn't mention this earlier, but is another thing whenever you're talking about products is to, excuse me, many families use hand-me-down products. And so that's a whole nother component to factor in. I know when we looked at the cribs in the homes, we documented the year they were manufactured and if they were on the Consumer Product Safety Commission's list of safe cribs. So something to think about for other kinds of products. Um, and here we go with the self-report. How has the baby slept most often since the last interview? And here you see the ABCs: alone with no people, alone with no objects, on the back, in a crib, pack and play, or bassinet. And on the bottom row, you see all safe. And then you can see we have daytime sleep and nighttime sleep, intervention group versus standard group. And it's important to point out for safe sleep, parents have very different patterns for daytime versus nighttime. So it was important to segment that. And what we have here is 72% versus 52% in the daytime sleep columns, with the intervention group significantly higher rate of reporting all safe. And similarly for nighttime sleep, 94% in the intervention group versus 63% in the standard group, both significant differences. So we were pleased with those results, and I hope that gave you a good example of how you might use this in a real world setting for an important child injury problem. So let's summarize this precede proceed framework. Um, the hallmarks of the model are that it emphasizes participation of the intended audience and the interventionists at every phase. We find that to be ethical and pragmatic. It's ethical because many of the behaviors that you're going to work on, whether it's an injury or any other kind of behavior, are personal. People need to make informed decisions about what behaviors they're going to do. So it's ethical, and also pragmatic, because years and years of experience have shown us that if you involve the audience who you're trying to help change behavior, you're going to have a better impact than if you decide from the four corners of your office what they should do and how they should do it. It's flexible, especially if you get comfortable with the concepts. And I liken this to anybody who is a cook. Um, the first time you do a recipe, probably follow it to the letter, measuring everything, mixing it the right amount at the right speed. But after you've made it a few times, tweak it here, you tweak it there. It's just something that you're very comfortable with doing. And you wouldn't think of building a behavior change program without giving consideration to the important components of planning and strategic linking your intervention to what you need to have change. Um, it also builds evidence-based and evaluatable behavior change programs. And we're all in public health, all about evidence-based work, and that applies to behavior change like it applies to every other program or project or policy that you're going to work on. And it's a platform for evidence-based practice and practice-based evidence, a term of art that is very widely used by Dr. Green and health educators, that we definitely need practice-based evidence to have evidence-based practice. So I hope these examples that are from the real world, but are hopefully done with attention to rigor, give you some ideas about the meaning of evidence-based practice and practice-based evidence. So I firmly believe that using this model builds effective health behavior change programs, not just for injury, but for any public health problem, because it leads the planner to create programs that go beyond information sharing, to understand that behaviors occur within environments that make it easier or harder to act safely or healthfully, and that address individuals and their environments and make the safer or the healthier behaviors the easier or the default behaviors, which is what we strive for. Now, I know you're all waiting to hear this, and I don't know if you've guessed it already from the beginning. What do those acronyms stand for? So here's the slide that will tell you what all those acronyms mean. And you can read that for yourself. The simpler way to understand it is just remember that you must precede before you can proceed. Assessment and then building programs, implementing, and then evaluating them. And lastly, but certainly not least, failing to plan is planning to fail. So, as a roadmap to success, Precede Proceed is a planning tool that will help you prevent plan failure. And with that, I thank you for participating in this session, and I have some assessment questions for you at your leisure. Um, I hope this has let you be able to provide 3 examples of behaviors that can reduce the risk of childhood injury. You can identify 2 types of intervention strategies for our PRE factors, and think about how you might use behavior change interventions in your own work. Here are our references. And for more information on these 2 great organizations, please just scan these and enjoy the rest of your time in public health. It's a great profession.